This week on the BackTable podcast,
we use neuroendocrine neoplasm as the umbrella term, and then within that, we classify them as neuroendocrine tumors and neuroendocrine carcinoma. I tell patients this is a whole spectrum of very different diseases. On the one end of the spectrum, we have the very indolent, very slow-growing ones. Those are generally the neuroendocrine tumors. And then on the other end of the spectrum, we have the very aggressive ones, generally the neuroendocrine carcinomas. And then we have everything in between. So the WHO classification, we classify them based on differentiation, which is their morphological appearance of the cells under the microscope, whether it's well differentiated or poorly differentiated. And then based on grade, which is how proliferative these cells are, how much they're copying themselves. And we assess that based on mitotic index and also something called the Ki-67 stain. And like you said, we really need an experienced pathologist because we, like you, have seen many cases where the diagnosis changed drastically after being reviewed at our center.
In this episode, we'll discuss the diagnosis and initial management of neuroendocrine tumor. My name is Lingling. I'm a GI medical oncologist with Ochsner Medical Center in New Orleans, Louisiana. Today, joining me, I have the honor of hosting our guests, Dr. Xavier Liao and Dr. Keutgen. Dr. Liao is an associate professor of medicine at the University of Chicago. He's a medical oncologist who specializes in hepatobiliary cancers and neuroendocrine tumors. He serves as the medical director of UChicago Medicine's Hematology Oncology Clinic, the interim director of GI Oncology Program, and the co-director of the Neuroendocrine Tumor Program. Dr. Xavier Keutgen is an associate professor of surgery, director of Neuroendocrine Tumor Program, and director of Theranostic Program at UChicago. Welcome, Andy and Xavier.
Thank you.
Thank you for having us.
So today we're going to have this exciting talk about neuroendocrine tumor. When it comes to neuroendocrine tumor, I definitely feel that this is one of the tumors of which the pathology is very confusing, sometimes not only to the medical oncologist and sometimes even to the pathologist as well. I definitely have seen many patients who come to see me with a diagnosis of neuroendocrine carcinoma on their problem list, but of course they never had neuroendocrine carcinoma but had neuroendocrine tumor instead. I even saw patients, like pathologists sign out a report saying that the patient had a well-differentiated neuroendocrine carcinoma with a Ki-67 of 1%. So the pathologists call that, but we all know that that's not a neuroendocrine carcinoma. So Dr. Liao, would you like to give us a one-liner general idea, the relations and the difference between neuroendocrine neoplasm, neuroendocrine tumor, and neuroendocrine carcinoma?
Yeah, it's super confusing, like you said. And, we use neuroendocrine neoplasm as the umbrella term, and then within that, we classify them as neuroendocrine tumors and neuroendocrine carcinoma. I tell patients this is a whole spectrum of very different diseases. On the one end of the spectrum, we have the very indolent, very slow-growing ones. Those are generally the neuroendocrine tumors. And then on the other end of the spectrum, we have the very aggressive ones, generally the neuroendocrine carcinomas. And then we have everything in between. So the WHO classification, we classify them based on differentiation, which is their morphological appearance of the cells under the microscope, whether it's well differentiated or poorly differentiated. And then based on grade, which is how proliferative these cells are, how much they're copying themselves. And we assess that based on mitotic index and also something called the Ki-67 stain. And like you said, we really need an experienced pathologist because we, like you, have seen many cases where the diagnosis changed drastically after being reviewed at our center.
Exactly. And then I also feel the neuroendocrine tumor is like one of the cancers that definitely have a lot of heterogeneity, even in one patient, like within one body. A lot of experience that we resected at stage 3, say small bowel neuroendocrine tumor, and the Ki-67 in the lymph node is actually way much higher than the Ki-67 is the primary, say the small bowel primary. Or sometimes when patient presents with like metastatic stage 4 disease, if we biopsy both the primary and say a liver met, and very often I found that the Ki-67 of the liver met can be much higher than that of the primary. And how much do you trust the Ki-67 of a single biopsy in someone presented with metastatic disease?
Like you said, we can see variability, in the tumor grade within a single patient, and even more pronounced after treatment, actually. Sometimes after the tumor has seen multiple lines of treatment, we see like different clones of tumors emerge that behave very differently.
And I would say, to answer the question, how much do we trust it? I think a single biopsy is never a very good representation, right, of of ultimately what the disease is like. But I think there are two aspects to that. The first one is, does it matter, whether you're dealing with a grade 1 or a low grade 2? I mean, probably not. So I don't think it changes our initial management. Now, of course, like Andy said, because it is a large spectrum, if it turns out to be a biopsy that shows a poorly differentiated neuroendocrine carcinoma, that does matter in that case. But if you are within the well-differentiated spectrum, it probably wouldn't matter that much unless, you're looking at a well-differentiated G3 with perhaps a dotatate PET that doesn't show any uptake, so that's a tumor that doesn't express somatostatin receptors, then it does matter because then it changes what Andy or what I would do. But I think in general, whether you're dealing with, a well-differentiated G1 with a Cas serum of 1% or G2 at 5%, I don't think it primarily changes our management per se. So we just go with what we have ultimately, because there's really no better way in that moment to know what we are dealing with unless we do an operation or we do multiple biopsies, at which point we have multiple specimens.
You're right. That I definitely agree with that. I was actually chatting to another oncologist the other day, and he said neuroendocrine tumor is really a cancer that you don't know how fast the horse is running until the horse starts running. And I definitely feel the same way. Like, I definitely have patients like let's say it's lung, typical carcinoma, keep growing, and then we biopsy the very aggressively progressing site, and it's still Ki-67 is like less than 1%. So you were like, and it's like not even FA or FDG PET. So I definitely feel that a lot of times we just have to go with like the clinical course.
Yeah, biology is king, right? I mean, you could have two patients with the same specimen on biopsy. Look, even on the microscope, looks exactly the same. It's the same grade, but they will behave completely differently over the lifespan. So there's much more than just a grade in the biopsy results.
And then when it comes down to staging and restaging modalities like scans, a lot of times I'm like, I don't even have a perfect answer for that either. Like when we're like first staging and then when we keep doing surveillance or restaging scan, I definitely have seen like very drastically different practice. I've seen providers ordering only CT scan of the chest, abdomen, pelvis with contrast, not even a liver protocol for years in restaging. And then sometimes you can miss like small but diffuse perineal disease, and all of a sudden you do a PET scan. It looks like the cancer have progressed a lot, but in fact, not really. It's just you haven't done a PET scan for a long time. But I also have seen providers ordering all 3 scans, a dotatate PET scan, plus a CT chest, abdomen, pelvis with contrast, plus an MRI abdomen with contrast every single time. Not even in patients with metastatic disease, sometimes in patients with complete resected disease, like stage 3, stage 1 disease resected. And every 6 months they're doing that. And patient had no evidence disease. So my question for both of you is like, when patient first came to see you, when it comes to initial staging, what do you usually order? Is it a dotatate PET scan, an MRI abdomen, or CT abdomen, like triple phase liver protocol?
I would say for localized disease, it depends a little bit on what kind of disease we're dealing with. So, if you look at, for example, a small, pancreatic neuroendocrine tumor that's less than 2 centimeters and doesn't necessarily meet guidance or guidelines for resection, at that point, we have done dotatate PET CTs on our patients, mostly because they are nervous. These are usually incidentally found tumors on a CT scan for another reason. And so we do the dotatate. It never really shows anything else, in a very good concordance with the guidelines that these tumors, when they are small, are very unlikely, especially if there's no signs on a CT or an MRI, to have metastasized somewhere else. But I would say that prior to going to the operating room, it does matter to understand what the disease looks like and what the staging is like, because, sometimes, like you mentioned, you can have disease deposits in sites that are a little unusual and that you're not necessarily going to look for. And therefore, I would say that, let's say I take somebody to the operating room for a right hemicolectomy because you have a small bowel neuroendocrine tumor, even with a regional lymphadenopathy seen on the CT scan, I would absolutely get a dotatate PET, just to be sure that, there isn't anything somewhere else that I would miss or that I need to go for. That could mean a small few lymph nodes at the root of the mesentery. Sometimes you have some retropancreatic or like periortic nodes or retroperitoneal nodes that light off positive. Sometimes you have some skeletal disease that you will never otherwise pick up. And it matters all for postoperative management and how we surveil them postoperatively. But so I would say for localized disease, depending on what you're dealing with and what your next step is, I would say an initial CT and or MRI, depending on where your disease is, plus a dotatate PET, I think is a good move just to kind of get a feel for the land and see, what you're dealing with.
Yeah, and for metastatic disease, it kind of depends on what you're looking for, like where are the metastases. We generally like patients to at least have an initial dotatate PET so we can understand whether their tumors have somatostatin receptor expression or not, because then we want to see if they're candidates for PRRT. And then for patients who have liver metastases, especially at our center, because Dr. Keutgen specializes in liver debulking, we really want to visualize the lesions very clearly. So we prefer doing an MRI with hepatobiliary phase contrast, like EOVIS contrast, that can really, really show these liver lesions very clearly. So we prefer that over like a CT triple phase protocol. And then, if you're looking at the bowel or mesenteric disease, specifically for, correct me if I'm wrong, Xavier, specifically for surgery, sometimes you'll need a CT, right, to look at the relationship with the mesenteric disease and the vessels. And then bone disease oftentimes don't show up on CT or MRI, and sometimes the only way we can see them is through a PET scan. And so oftentimes it's a combination of all three of these modalities, kind of depending on the pattern of each patient's disease and what you're looking for. For patients who have, let's say, liver predominant disease and maybe some bone disease, we may get the MRI more frequently, every 3 months, and then the PET scan maybe once a year.
That's the key, is to understand, what is the pattern of disease and adjust according to. Because like Andy said, for example, for mesenteric nodes, they're not well seen on MRI. And so for me, for preoperative planning, it's important to know, I can tell from a CT scan where your nodes are. Are you going to need a right hemicolectomy or just a small bowel resection? Why does it matter? Well, it matters because, I can consent and my patients appropriately. And I can also tell them, do you need a bowel prep or not? Which many patients don't like. And so, if I see nodes that are around the ileocolic vessels, I know it's going to be a right hemicolectomy. Even if I don't see the primary tumor, I know that the primary tumor is going to be in that area. But if it's in the middle of the small bowel, they won't. And so I won't have them do a bowel prep. So studying these studies carefully really, really makes a difference. And then I will say, and Andy, correct me if I'm wrong, but we rarely use chest CTs. Because the truth is, these tumors, unless they're obviously primary lung neuroendocrine tumor, rarely metastasize to the chest. They can metastasize to, mediastinal lymph nodes. They can metastasize sometimes even to the pleural, although that would be very rare. But sort of doing like a routine chest CT for screening or for surveillance, we rarely do. If they are mediastinal lymph nodes, you usually can see them very well on the PET. And like Andy said, doing a PET scan, generally once a year is good for most patients. But not of course, if you're fully resected. So if you're fully resected, this was localized disease, and you went for cure, surgically speaking, you wouldn't do a PET scan on a yearly basis. We would even span it out even further than that. Maybe every other year or
right.
something.
I usually would do a PET, like if it's truly surveillance, like there's no evidence of disease, I usually do PET scan, say when I have a question. And I do feel I agree with both of you that I think, say, when we're seeing a stage 4 patient and doing a restaging scan, usually my approach is like, where are the diseases, right? If I really want to measure the size of the lesions in the liver, then of course, when I get a PET scan, I have to get an MRI, because I also have colleagues who are like, get PET scan, but not an MRI. And then all of a sudden on this PET scan, there's this like one newly avid lesion. But if you really have been getting an MRI, that lesion have been there. It's just all of a sudden become bright. So
Exactly.
Or if they say like the SUV went from like 15 to 19 and they call it progression.
Exactly. That does happen a lot.
Yeah, so that's important, I think, for our listeners, right, to understand that an increase in uptake doesn't mean an increase in tumor size or new tumors. So it doesn't necessarily mean progression. I think that's something that very often gets confused on the PET scan results.
Exactly. That was what we're like trying to discuss as well. Like progression on the scan basically means there's new lesions or there's increased size of existing lesions, but not like, it's not FDG PET for lymphoma, right? We don't call progression based on increase in SUV. I think that's a very, very important part, because I do also see a lot of radiologists still calling that like there's progressive disease, but that's really just look brighter on the scan.
For sure.
Right. And then sometimes we do get like discordant imaging results. For example, there may be some lesions they're seeing on the CT, but not avid on the MRI, but not avid on the dotatate PET scan. Like, how would you follow up on these results, and what else will you do to follow up on that?
Yeah, we definitely see that. And sometimes it's like a mix. Some of the lesions are dotatate avid. Like you see them on the MRI, and then some of them are dotatate avid. Some of them are not. And if you do a FDG PET scan, you can also see that some lesions have more hypermetabolism than others. And sometimes we have to think, what is the best way to follow these patients when their tumors are so heterogeneous. And unfortunately, many times insurance doesn't like us doing both types of PET scans.
Yeah, that's how I feel. Like sometimes I need to do FDG PET scan to see if it's more bright on FDG PET. I think that will come down to heterogeneity of neuroendocrine tumor, right? But I also have a patient who has been having like stage 4 metastatic small bowel neuroendocrine tumor with like liver mets, have been under very well control on somatostatin analog. And there's this one lesion which kept growing. And then on the dotatate PET scan, that specific lesion is not avid. So her oncologist sent her to us to consider PRT. So we actually biopsied that lesion because on the CT scan, it looks very much like a cholangio to me. So we biopsied that lesion and it actually turned out to be cholangiocarcinoma. So sometimes when it's not very bright on the dotatate PET scan, I will also biopsy just to make sure that we're not missing anything else. Next, we're going to switch gear and discuss biomarkers because like completely different practice, right? Some people check a lot of biomarkers. Some people don't check biomarkers a lot at all. Do you check biomarkers on all of the patients when they come in? If so, then what do you check?
So we don't routinely check biomarkers is the short answer to this. I think, again, it depends on the patients. I think, as we all know, there are functioning and non-functioning nets. And then there are these nets, whether they are functioning or non-functioning, that you have a biomarker for, which is called chromogranin A. That's probably the most common one that most people would do. So if we're talking about chromogranin A, I don't want to speak for Andy here, but I think he's on my page, that we are not big believers in chromogranin A, especially for diagnosis, because it is really a reliably unreliable marker in the sense that there's a lot of false positives. If patients are on PPI, for example, they can have very high chromogranin A levels. So often our patients come referred to us and already have a chromogranin A. So if we have one at baseline, occasionally we will use it for follow-up. But I would say that we'd never rely on a biomarker alone to be diagnostic. I think that's, really the important part here. In terms of functioning neuroendocrine tumors, so if it's a small bowel neuroendocrine tumors and patient present with carcinate symptoms, flushing, diarrhea, wheezing, etc., then we can often bet on serotonin, which we use as plasma serotonin, but you could also check urinary 5-HIAA, to be high in those patients. I do think in those cases it matters because that actually is a pretty reliable biomarker, and it is a marker that definitely we can follow, and it can sometimes, and actually most often, really correlate well with symptoms. So let's say, we have debulked somebody or we have started a therapy like long-acting octreotide, and the patient's tumor is, stable, not growing, but they keep having symptoms, and the serotonin level is still high, then I think, we have to think about adding something else, right? Or after surgery, if patients have diarrhea, which commonly can happen after small bowel or large bowel surgery, their serotonin level has dropped and is normal, then we know it's not the tumor. So there's something else going on, right? Could be malabsorption, it could be something else that's related to the surgery. And so intervening depending on that is actually very helpful. For pancreatic neuroendocrine tumors, there's a whole bunch of biomarkers that we all know, for functioning pancreatic neuroendocrine tumor, that's gastrin, insulin, which are the two most common. And then there's the very rare ones like VIP, somatostatin, glucagon. And I think, from our perspective, gastrinomas and insulinomas, which are pretty much the only one that we see. It's very rare to have a VIPoma, but all of them are not subtle. These are not subtle type of, I have a little bit of acid reflux, so I have a gastrinoma. No. Or my blood sugar dips just a tiny bit, so I have an insulinoma. No, it's not. It's really like I'm hypoglycemic, I pass out, my car is running in the tree and I don't know why I did that, or I'm having such bad acid reflux and no matter what I do, it just doesn't get better. I had an EGD and had multiple ulcers, so we don't routinely check markers for pancreas because the majority of them are non-functioning, and those that are functioning, generally, if you take a good history, you'll know exactly, already what you're looking for. And then we'll check, of course. If we have a suspicion, we'll check, but we don't do it routinely.
Yeah, I completely agree. And there are some situations like, type 1 gastric carcinoid or gastric carcinoid in general. Sometimes checking the gastrin can help us differentiate the type. And the other thing is we also caution patients, because if you check a serotonin and it's going up, of course, that provokes anxiety in the patients. But we tell patients, like, just because the serotonin is rising doesn't necessarily mean the disease is progressing. Sometimes it's just, making more hormones, and maybe we need to just step out our game in the symptom management part.
Exactly. That's how I feel. I actually do agree that I found that the only time that it's helpful would be this is a functioning tumor, right? We know that these hormones will be elevated and we monitor over time. It kind of gives me a little bit of idea like how active the disease is. Like when we look at the next scan, if it shows progression, I'm okay. I kind of expect it to be coming. But I also I check serotonin, I check serum, and then 5-HA, I actually check serum as well. And then, of course, after you eat, it will be elevated. So I definitely have patients see it coming up. So oh, freaking out, what's going on? But exactly like you said, we actually go by scans, but if keep going up, like patient having more diarrhea and everything, of course, we need to do something like maybe liver-directed therapy or something, or adding something to make their symptom get better as well.
And to your point with Dolatit before, there are these few but rare cases where, you are following with an MRI, because high chance of recurrence in the liver, or maybe there are some liver mets and nothing else anywhere else. But then your serotonin level keeps going up. Your MRI doesn't really show anything that's really significant. Then that would be a case where we would probably do a PET, to make sure that we're not missing something outside of what we're actually looking for. So there are these cases where it can give you a hint on when to use what scan as well.
Yeah, I definitely have that, the serotonin keep going up, but CT is always negative. That will actually push us to do something more sensitive, such as MRI and PET scan for sure. And then question for Xavier, as a surgeon, for patients with limited metastatic disease, when will you consider surgery for a patient? And who are the ideal candidates? Just give us a general picture who we should be sending you.
From a surgical perspective, we generally would want to look at a couple of things. Number one, biology again, right? So if you look at, why we do the operation, even with a few metastases, the chance of recurrence is very high after surgery. Once the tumor is spread and is spread to the liver, and like the cat's out of the bag, even though we can resect all of the tumor and nothing's left behind that we can see, we have to assume there's micrometastatic disease behind, and that disease will grow back over time. Could be many years. We've studied this actually. And, for small bowel neuroendocrine tumors, it could be 3 or 4 years sometimes until some tumor grows back after liver debulking. But most of the time, we want to assure ourselves that before we take somebody to the operating room, they are a good surgical candidate. Obviously, if they are 90 years old and had 4 heart attacks, it's probably not a good person to take to the OR. Number two, that the biology is reasonable, right? So with small bowel neuroendocrine tumors, that most of the time that's the case. With pancreatic neuroendocrine tumors, we see every once in a while, and we want to trial them out on, let's say, a long-acting octreotide for 3 or 6 months to make sure we get disease stability before we take them. Because there are these surprises with PNET sometimes where, they can progress more rapidly, even though the biopsy grading shows that it's a low grade 2, for example. And so we want to make sure that we select based on as much information we can have for tumor biology as well. And then tumor burden matters, tumor location matters. So let's say most of your liver replaced with tumor, I'm not going to be able to do much. for you. If on the other hand, you have, and every surgeon has a little bit of a different cutoff, but let's say it's less than 25% of your liver replaced with tumor, then generally we can target it. Depending on where the tumors are, how big they are, these are all things that we factor in, because the way we do these operations are not the usual, I'll take the right side of the liver out, or I'll take the left side of the liver out. It's like we target each lesion individually. We call it parenchymal sparing resection. So we carve them out, we stick catheters in them to burn them. And so you can have disease throughout your entire liver, but as long as the disease is in locations where I can get to it and I can destroy it and it's not overwhelmingly replacing your liver, I can usually get to a pretty good debulking threshold, which, as you know, most people have defined as classically 90%. So you would want to get 90% debulking in order to have a good outcome in terms of survival. Newer data, it's not that new now, but said maybe 70%. I try to aim most of the time for 90% or greater. I think so. Patient selection does matter because these are also big cases. You want to make sure that you do the right thing. If the patient doesn't leave the hospital because we have overshot ourselves in terms of what we're doing, then we haven't served anybody, because most of these patients, as you know, can live many years even without surgery. So we really want to be careful in who we do the surgery on and making sure that that makes sense, which is why a multidisciplinary approach, and also making sure that Andy, gives his comments and tells me, look, I think it makes sense in this case, or it doesn't make sense to do a surgical debulking, is very important.
But when you're considering this, like you said, like the pace of tumor is very, very important. If it's like very aggressive, fast growing, probably not the best candidate. Does Ki-67 play a role when you're considering, like, based on whatever information that we have?
Ki-67 alone, no. I mean, I can remember just a case we did maybe a little over a year ago where the patient had a pretty young patient, has a grade 3 PNET with, I think, 2 or 3 liver metastases, one of them pretty large right in the center of the liver, and we knew it was a grade 3 from biopsy, but there was some statin receptor uptake, which is generally always a little bit better sign, right? Because you know that probably these tumors might be treated down the line with PRT or with long-acting octreotide. And because he was young and this thing was in the center of the liver, we knew it's going to cause problem if it's growing. And so we went after it. We did resect it. And it's been a year and a half and he hasn't had any recurrence yet. So again, grade matters, but it's not everything. Grade doesn't necessarily predict biology. And so I think it's always an individualized discussion based on patients' wishes, what the tumor board and the specialists think makes sense. And then, we make a decision. Of course, poorly differentiated necks, yes. I mean, those don't go to the operating room. Almost always. I mean, unless it's localized, you're very lucky and you caught it. Let's say it's like a colonic poorly differentiated neck, that was discovered on a screening colonoscopy, has no mets. Yes, you're going to go and you're going to resect it, But if it's metastatic, most of the time, we won't go close to it.
So how about, say it's a localized pancreatic primary, but it's well-differentiated high grade? It has not spread yet. So Ki-67, and the patient's a good surgical candidate. Say Ki-67 is 45% versus, let's say, like 65 or 75%. Like, how about that?
Sometimes we start systemic therapy to test the biology.
Right. So there is things like CAPE-10 that we can give, for example, or if it's well differentiated and has so much statin receptor, we could try them on octreotide. But I would argue that, if you have a young patient, with a tumor, let's say in the head of the pancreas, that's Ki-67 of 45%, and there are no distant metastases, that's going to cause a problem. This tumor is going to cause a problem because it's going to invade in the bile duct, it's going to cause jaundice and all kinds of things. So I personally would go for a Whipple. Even easier if it's in the tail of the pancreas. But again, 65 versus 45, I can't remember having operated on a patient with a well-differentiated G3 at a Ki-67 of 65%, at least not that I knew before surgery. Maybe it was a surprise on the pathology, that it came back at 65%, but I can't remember that I've seen this patient in over 10 years doing this. So
Right.
It's a very hypothetical question.
It's very, I never had 65%. But I did have 45%, and it was an 80-year-old, although a very healthy 80-year-old that will need a Whipple. So that
it's tricky. That's tricky.
Right.
And in an 80-year-old, it's tricky.
Right.
Yeah,
right,
for sure.
Yeah. So that patient Our surgeon actually did offer him surgery because he's actually very healthy, but patient himself does not want to spend a year trying to recover from Whipple. So we treated him with a year of K10, and so far he's still doing pretty well.
Yeah, and I mean, that's really important to say that, right? Is that any operation, especially on the pancreas, especially in the head of the pancreas, can have significant comorbidities. And even though we're very good nowadays at doing this operation very safely with a very low mortality rate, complications happen, even in the best medical centers with the best surgeons. And so complications can set you back many months, and sometimes, like you say, 6 months or more. You got to think about what you're dealing with, because if you suspect micrometastatic disease, that's a hell of a long time for this disease to recur and come back. And if you can't treat people well during that time because they are recovering from their surgery, then you're losing time. So it's really important.
Right. Then how about, say, it's a well-differentiated low-grade neuroendocrine tumor in the pancreatic head, and it's a Whipple, and it's above 2 centimeters, so we need to do surgery. Would there be times that you feel that this patient, like young patient, say, not an 80-year-old, but because of comorbidities, like what kind of comorbidities that you will feel that are probably not the best candidate for surgery? And I personally feel that we see more and more patients like that. And nowadays, it seems like morbid obesity also plays a role in that. How do you feel about that?
Yeah, so we have a couple of patients that actually are in this exact situation, It all depends, right? First of all, if you think about bariatric surgery, they have operated minimally invasively on obese patients for a long period of time. Now, of course, a gastric sleeve is not the same operation than a Whipple, but there are newer ways in surgery to address this. Some are robotic Whipples, is one example. What I like to do is actually try to enucleate rather than do an actual Whipple. So I will try to avoid a Whipple at all costs, almost every time I can, for the simple reason that it is a much more morbid procedure, especially in somebody with a high BMI or somebody with higher comorbidities. The enucleation part is really nice, but it depends on where the tumor is in relationship to the main pancreatic duct and the bile duct. And if you can enucleate it, my personal bias is you should. If it's in the setting of metastatic disease, even more so, because the cat's out of the bag, the tumor is going to recur anyway. So you're really trying to carve the lesion out of the pancreas to prevent things to grow into the bile duct down the line. And so I will really try to do a pancreas preserving surgery as much as I can for neuroendocrine tumors. That's the first step. The second part is that, ultimately, again, it's a multidisciplinary decision. Right? We have patients that are not good surgical candidate or sort of really borderline surgical candidate. We want to test out the biology. We put them on long-acting octreotide and then we see what happens, And that gives them also time to maybe go on a GLP-1 or something like that and work with our weight loss specialists to lose the weight, to get in better shape, and then if the tumor is still localized by then or hasn't really progressed, then we can wait a year or two sometimes until we do an operation. So again, these are all multidisciplinary decisions. There's many things we can do together. And with long-acting octreotide, many times we can freeze these tumor in time for a little while.
Yeah, that's a great point. Especially, I'm glad that you bring up the GLP-1. I definitely have a few patients with like PNAT that they actually need Whipple, but the surgeons feel that it's very high risk. One of the reasons patients are like morbidly obese. So the easiest way right now is to get on GLP-1 agonists. But we also know that it's a controversial area that we actually do not have any evidence to support or against to put these patients on GLP-1 agonists. I wonder, Dr. Liao, what do you usually consult your patient when they were like, okay, I have this PNAT, small bowel net, whatever net that I actually need to lose weight. Can I take a GLP-1?
Yeah, like you said, we really need more data to help guide our decisions. Right now, we allow our patients to get it, I think, unless they have, MEN syndrome. But otherwise, we say go for it. But we need more data to help us guide these decisions.
Right. In your clinical experience, do you have a feeling? Because for my patient who actually have been on it, I don't really see the neuroendocrine tumors like progressing very fast. Do you have a feeling that once they are on it, then the neuroendocrine tumor grow fast or anything like that?
No, not in our experience.
That's how I feel as well. But of course, we need more data. But of course, if people have insulinoma, I would say probably get on GLP-1 is not a good idea right now. And then just last few questions for Dr. Liao. This is a question that I actually encounter a lot. Say for patients with stage 3 neuroendocrine tumor after surgical resection, regardless how bad it looks, like lymphovascular invasion, whatever, like 6 lymph node involved, do you offer them adjuvant, quote unquote, adjuvant Somasa analog?
I don't, just because I don't think there's any data that shows that it reduces recurrence or helps people live longer. For pancreatic neuroendocrine tumor that's resected, if they have high-risk features, there actually is a clinical trial going on looking at doing 4 months of adjuvant capecitabine temozolomide, CAPE-TEM, which is a chemo used in a metastatic setting. So that trial is accruing nationally. We'll see what the results show.
And that's remind me, for well-diff grade 3, right? Was it?
It's for well-differentiated grade 1 and grade 2, but they had to have high-risk features. So there's something called the XID score. So, the size of the tumor, the Ki-67, whether there's lymph nodes involved, whether the patients were symptomatic at presentation.
Interesting. So we'll see in a few years what the results show and hopefully guide us further. But I share the same way. It's like usually if it's completely resected disease, I don't put them or anything and I just do surveillance.
Sorry, if I can put a plug in for one of the studies that we did and a prospective trial that hopefully will start soon at our institution. But even for metastatic disease, after we've debulked them, we looked retrospectively, and there's a paper that we published last year on doing like adjuvant long-acting octreotide versus not. So this is stage 4 now. They have been debulked. Who gets it and who doesn't? Almost every place, I think, that debulks puts people back after surgery on long-acting octreotide for the simple reason we talked about it before, that we have to assume that disease is left behind, even if you removed everything you can see. But we have found in that study that the patients that we actually restarted post-op on long-acting octreotide did the worst, because out of intuitively, we probably already are selecting the ones that we know are not going to do well. So their progression-free survival was 1 year or less on long-acting octreotide after debulking. So these were higher grade PNETs, patients with extra-abdominal disease, et cetera, et cetera. Interestingly, though, the study was most helpful, I think, at cornering out a patient group that does well after debulking, and that's small bowel neuroendocrine tumors, well differentiated, with no extra abdominal disease, that have had debulking at 90% or greater. So those patients, we found that it took an average of 3.5 years for them to have progression again, and then go to be restarted on long-acting octreotide. And again, we think of it as, Andy would say this all the time, it's a marathon and not a sprint, right? So if we can get patients off therapy for 3.5 years, it's a big benefit for them. They don't have to go every month to the doctor. They forget more about their disease. And, we all know it's a pain in the butt to get this shot, literally, right? And so I think now we have to show, if once we restart them, how long does it extend, right? But do we lose anything? But probably we won't. That's my intuition, And so just as a plug here, that not everybody, even after debulking for stage 4, necessarily has to go back on it. There is probably a selected patient group that has, again, good biology, and no matter what you do, they'll do well. And so we are doing a randomized prospective trial to try to tease out what the exact details are, which we hope we're going to start with in the next 6 to 12 months.
Yeah, that would be a very interesting study, and I look forward to the result. But I definitely feel that also shows how heterogeneous this patient population is, right? Some just have great disease that no matter what you do, they're going to be fine.
Yeah, they'll do well.
Exactly. Others is like, regardless what you do, they just keep progressing.
Exactly.
Right?
But then not over-treating those that do well is also our job as clinicians, right? But it's sometimes so hard to find out.
Exactly. Exactly. I completely agree.
That's what's difficult.
Okay. So I have this case. He is a 58-year-old man. He does have comorbidities. His morbid obesity, BMI is 38. His diabetes, hypertension, was really incidentally found to have a locally advanced pancreatic neuroendocrine tumor. It was not functional, and they biopsied the Ki-67 7 to 10%. So not super high grades, lower grade 2. He had a CT abdomen pelvis that was actually what found out that he has this tumor, 9.5 by 8.6 centimeter mass in the pancreatic head, abuts the gastrointestinal and duodenal bulb, abuts the IVC less than 180 degrees, encroaches the left renal vein, although a thin preserved fat plane is present, abuts the undersurface of the portosplenic confluence less than 180 degree, and partial encasement of the SMV of 180 degrees. So I do have, that's not fun. Let me show you the CT scan.
It's pretty close to the SMA there too, actually. It's abutting the SMA.
The thing, it also spread to local regional lymph nodes. but it's still locally advanced. Like there's no metastatic disease.
Well, as far as we could tell.
Right. As far as we had a PET scan, here's the PET scan. But basically, it's just this pop of color with a locally advanced pancreatic neuroendocrine tumor, and also there are lymph nodes around it that were bright as well. So for this patient, locally advanced pancreatic neuroendocrine tumor, non-functional cases of 7 to 10%. He does have morbid obesity, hypertension, diabetes. What would you do as the first step?
Yeah, that's a great case for TumorBoard, right? So if Andy shows me something like this, I would say I would like to have some form of systemic therapy. And again, it's all depending on the goals of the patient, right? But if the goals are to get him resected, so the patient is on board with resection, right now I would not resect him. This is too risky. And then you said, we don't see anything else on the PET, but the truth is very often, the reason why these patients recur is that very often they already have micrometastatic disease, especially when it's that locally advanced. So they probably already have micrometastatic disease in the liver that will pop up over time. So I would like to get some disease control, number one. And number two, I'd like to ideally get shrinkage. And so when I say shrinkage, Andy will say...
Yeah, so, in this situation, we would consider using capecitabine and temozolomide. There's many systemic therapy options, but out of all of the systemic therapy options for well-differentiated PNETs, CAPE-10 probably has one of the highest response rates, and the shrinkage happens relatively quickly. And so for those reasons, we would consider CAPE-10 in this particular situation.
Right. That was actually our recommendation as well. Our surgeon feel the same way. He felt that I can resect it, but it's so high risk. And I first wanted to show me that it's not a very fast progressive disease to begin with. So that was also our recommendation as well.
And again, important to use that time while he's on CAPE-10, which most patients do well, right? To again, work on his comorbidities. Maybe he can lose some weight, prepare himself for surgery. I think that's key. But I would argue if the patient's not interested in surgery, then what would you guys do? Would you just give long-acting octreotide and then see what happens, basically? Probably, right? And then once he progressed, then move to the next line?
Yeah, unless he's symptomatic and we need shrinkage, then
right. He was not symptomatic, but I feel the same way. Where it's what's our goals of care? If we want to quote unquote cure and eventually come down to resection, we're probably more aggressive. That's why we want to do CAPE-10 and everything. But if it's incurable, say it's an 89-year-old, it's incurable, so we'll probably just do lanreotide. Okay, with that was a great conversation. Very inspiring. I learned so much from y'all. Thank you so much for joining us today. And that will conclude our session today. Thank you all so much.
Thank you for having us.
Thanks for having us.
It was a great discussion. Thank you.
Thank you.
Take care. Thanks.
Thank you so much for joining us on BackTable TumorBoard. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTableOnc. That's _BackTable ONC on Instagram, X, Blue Sky, YouTube, and LinkedIn. BackTable is produced and hosted by myself, Kate Baker.
Our production team is led by Kieran Gannon,
Aaron Bowles, John Reyes,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
Thanks again, and see you next time.